Jonathan, let's talk hip and knees. We get a lot of women complaining of creaking hips and aching hips and all sorts of knee problems. Can you tell us a little bit about what you see in clinic and why, you know, what's happening to us again, you know, as we age and from whatever exercise we do? I mean, I stupidly took up running age 40 and I didn't realize I had hip dysplasia and probably wasn't such a great idea, and suffered a lot of hip pain myself. So yeah, maybe you can talk us through a bit about what you see in clinic.
Sure. So the articular cartilage is not very big. It's a couple of millimeters thick in most of your body. It doesn't have a blood supply. It doesn't have a nerve supply, and it doesn't actually cause the pain. But as it starts to wear out, we start to get inflammation, and you can pick that up in the bone underneath the cartilage, and you can pick it up in the joint lining. So the first indication normally is pain. It can be associated with stiffness as well. Typically it's related to activity, coming on towards the end of activity or after activity. And then as James says, it doesn't heal because it's not got a blood supply. It can't really get any better. So it tends to sort of slowly but surely deteriorate. So the classic would be if someone has taken up running, noticing some pain in the groin from hip arthritis or knee pain at the front from knee arthritis, and then slowly but surely getting down from being able to run 10K to 5 to 2, and then realizing they have to stop running. And then often at that point, they're looking for some help. Typically it would be associated with some stiffness, so you might notice loss of range of motion. You might find that if you're doing your yoga, your Pilates, you know, you can't get into the positions you were previously getting at. And then, you know, for specific conditions, so you mentioned dysplasia. That's a condition where the hip socket is too shallow, so the ball doesn't quite fit into the socket right. That can present very early, can even present before birth or just after birth. But it's quite common, your story, where there's a fairly mild dysplasia. So there is a socket, but the ball's not perfectly in it, that people would start doing a new activity and then notice some pain. Mm-hmm. The good news for most people is that there's quite a lot of evidence now that if you do something like running and you're doing it carefully, you're actually helping your articular cartilage. So certainly in the 40 to 50 bracket, if you're doing it carefully, using good shoes, and you're sort of not overdoing it, so probably from the age of 40 onwards, you want to be running every other day rather than every day in a week pattern, then actually we've seen with MRIs you can make your cartilage look better.
By exercising, you mean?
Yeah, absolutely. So if you load them appropriately and properly, we can see increase in cartilage density. Unfortunately, we're not entirely sure how that's happening as yet. It's only been the last few years we've been noticing it on MRIs as the strength of the magnets have got amazing. We can see so much more now than we could 5 years or so ago. But it doesn't necessarily follow that running's bad. Yeah. And if you look at running in particular, if the peak, so if you do no exercise, you're completely sedentary, it's not great. If you do some recreational running, it seems to be pretty good. But if you're a very competitive runner, more wear again. So there does seem to be a right amount of exercise to do.
Absolutely. And what about the effect on a lack of estrogen for women? I mean, that obviously must have quite a, well, for all of you, really. Yeah.
Yes. So if you look at people over the age of 50, from 50 onwards, there's a noticeable increase in predisposition to arthritis in women. Mm-hmm. Obviously, that's a time associated with hormonal changes, but again, it's not something that's been very carefully proven. And there are some theories that it may be related to the fact that the hormonal changes reduce muscle strength. Potentially even some of the effects the hormones have on not being able to master your own sort of anti-inflammatory system within the body. So there's been studies for the last 15, 20 years showing it's there. But again, as yet, we haven't really understood whether, for example, using hormone replacement therapy is going to reduce the risks of arthritis. We've not shown that as yet.
Right, because I was under the impression it reduced the risk of osteoporosis, which is obviously quite, yeah.
Yeah, so osteoporosis, for those that are listening, that's a failure of strength of your bone, the main strength of it in the whole of the bone. Osteoarthritis, which is a worryingly, confusingly similar word to osteoporosis, is a wearing out of the cartilage on the ends of the bones where they form their joints. So osteoporosis, for sure, hormone replacement therapy helps. Osteoarthritis, it might, and you could say probably helps, but we haven't proven it categorically.
No. Okay, thank you. Andy, let's talk feet. Now, you must see a lot of midlife people who've taken up all sorts of wonderful things, you know, again, runners, and I mean, we hear in our group a lot of things, bunions and plantar fasciitis and all sorts of, you know, Achilles tendons going wrong. What do you see in clinic, and what, you know, reasons behind it, and what can we do?
So loads of things. We typically tendon problems, wear and tear problems. So tendon problems like the Achilles, wear and tear like arthritis, say of the big toe or the ankle, and injuries which can either be trauma, falling over and breaking a bone, or overuse injuries, which are things like plantar fasciitis. I suppose the reasons I tend to think of as four things. So your bones, we know that your bones are strongest, or you've had the biggest bone stock by the age of, I'd say, 25 to 35. Okay. And then thereafter it's downhill. All of your bone starts to fall off. And sadly, in females, when they hit the menopause, there's a much more rapid decline. And so you're more predisposed to having less bone stock. And hence, as I said now before, the risk of osteoporosis, which is less bone stock and fragility fractures, where a bone under normal physiological force could break. The next thing is the soft tissues, and that's a really important one. Soft tissues like tendons, muscles, and ligaments are made of a substance called collagen. And collagen, we all think of it as in the skin, and that's as you age, you get changes in your collagen. That's why your skin wrinkles. But they also happens the same in your tendons. And if your tendons, if your collagens become more brittle or less stretchy, then you're more prone to injury. We know other things like, I'm sure Addy's going to talk about this, but as you age, your VO2 max, or your fitness decreases. And we get other diseases like diabetes and vein issues, and all of these things make, sadly, as you age, they increase your propensity to having various different problems that we spoke about.
Mm-hmm. Okay, and what's a trick? I mean, I loved reading in your intro that you will try and avoid surgery wherever possible, which is obviously very reassuring for women. So what sort of non-invasive treatment options are there available now for, well, all the various different things you have talked about?
So for almost everything that we do, we try and avoid surgery. Surgery should never be the first line of course of treatment. And often the easiest thing, if you're driving a car with a handbrake on, is to take the handbrake off. And sometimes just looking at what people are doing wrong and addressing that. And that sometimes is their activities wrong, they're overloading, they're wearing the wrong shoes, they're running on the wrong surfaces. Those are very easy, quick fixes. Shoes are a big particular problem in my area, because shoes are responsible for a number of challenges. Training patterns, looking at training patterns, and getting people to use muscles that they haven't used before. More often than not, I see huge numbers of problems, not because of their feet, but because their core stability is weak. They've got really bad posture, really bad general strength, and in those situations, just retraining, going to see someone like Eric for rehabilitation, putting them on the straight and narrow actually often avoids the need for a surgical knife.
Yeah, absolutely. So thank you, Andy. Addy, let's talk about what you see in clinic. I'm just going to unmute you actually. Can you hear me? Yeah, there you are.
I can hear you, Kate, thank you.
Yeah, so, I mean, I had never heard about sports and exercise medicine until I needed someone like you. When I slipped my disc and everyone said, oh, you're going to need an operation on your spine. And I went to see a rheumatologist and they said, no, you're going to do sports rehab. And I was just amazed at the difference it made, actually. I mean, I managed to avoid every sort of intervention possible because of it. So yeah, tell me where you fit into this whole equation.
Thank you very much. Thank you, Kate, for giving me the opportunity to expand. So sports and exercise medicine has been a specialty that's kind of always been there ever since man came out of the cave and started fighting with each other. They needed somebody to patch them up. But it was only till when London kind of bid for the Olympics, and one of the remits that they put down was, look, if we're gonna, what's the legacy of the Olympics? The legacy is we're trying to encourage people to be physically active, and that's through exercise. And what are the main side effects of exercise? Well, it's injury, it's overuse injuries, or it's actually people who have not exercised before who are trying to get back into exercise, or the classic, actually my GP's told me to lose weight, but actually I've got a high blood pressure and I can't go and sign up at the gym because the gym don't want me to sign up because I'm too high risk. Where do those people go? So around the time when London won the 2012 Olympics, they formalized this specialty program, the specialty training program for doctors who basically specialize in keeping people active and getting them back into activity from whence they started. So as a specialty, we look after everyone from the elite athlete, professional sports, to the desk jockey, to the sofa surfer, to the weekend warrior. So that's kind of where we fit. And because for some of us, we've come from a trauma and orthopedic background like myself, we fit very nicely between the entirely non-operative management of ailments and injuries to actually deciding when somebody needs to go and see a Jonathan or an Andy or a Jim, because actually you can't just keep going forever having rehab. There comes a time where that decision needs to be made, and that's where we kind of fit in between those that field.
Mm. Yeah. And what sort of things will you do? Is it like being with a personal trainer, or is it a lot more sophisticated than that?
Well, I first of all, I couldn't assume I couldn't do what a personal trainer did. But imagine, say with your back, for instance. I mean, again, same with Jim. You'd come to see me with a back problem, a shoulder problem, a knee problem, and it's going back to the root cause. First of all, diagnose what the underlying problem is. So I will do the same history examination, investigations, just like with any of my colleagues. But then look at why has this happened? What can we do about it? And sometimes some of those presentations may be actually there may be an underlying medical reason for why that has happened. So somebody presenting, a couch to 5K person presenting with a leg pain or a shin pain, that may be the first presentation that actually they've got osteoporosis and they've got a stress fracture. And then we go down the investigations of looking at that and how to optimize that individual. So.
Mm-hmm. Okay, thank you very much. And we're going to go on to Eric, and then because I want to make sure we've got lots of times to ask you all questions at the end. So Eric, the last but not least, thank you for waiting so patiently. Now the physio is an ask we get all the time on our Facebook groups, and there's a lot of confusion between what's a physio, what's an osteo, you know, what's the difference, what's a chiropractor. But tell us a little bit, obviously, about what you do and the sort of things you see and how people can avoid, you know, pain and injury when they come to see you.
Yeah. So yeah, in our practice, we see pretty much everything. I particularly like injuries from about the waist down, so the hip, knee, and ankle. That's particularly my bag. But I see shoulders, I see backs, I see everything. I have neck and back problems. We all go through it. So we're just. I think really to summarize, what we try and do is just keep people moving, keep them active, and keep them healthy that way. Sometimes it could be an elite international squash player that I look after, and he's a bit worried about his hip being sore when he lunges into the furthest corner of the match. And sometimes it's just somebody who wants to be able to walk the dog. And so it really varies between whatever level that is. And some people, they don't even exercise. Lots of people don't exercise. And maybe my bias is to try and get them doing a bit of exercise, whether that's really specific stuff to help with their particular ache and pain, or generally just getting out there and doing something that's good and healthy for you.
So are the majority of people you see coming to you post-surgery, or is it a sort of mix of people who've just got aches and pains, especially through, you know, this last year we've all been very much stuck at our desk. You know, I keep going back to me, but I'm using myself as a perfect example. You know, bad neck, bad shoulder, you know, just from sitting all day and not actually getting out and walking about. Is it a mixed bag that you're
Yeah, for us, it's definitely a mixed bag. I see lots of people after they've had operations and helping them guide through their rehabilitation back to getting that outcome and that goal that they're looking for.
Mm-hmm.
The past year's been a little bit of an abnormality for all of us, really, and particularly, I think it's been really polarized. We've seen people who have got their aches and pains from doing nothing, from being stuck at a desk and not doing enough exercise and not being able to move around, and then we're seeing lots of people who've perhaps done a bit too much, a bit at the other end of the spectrum, where they've all of a sudden had 8 weeks of lockdown in front of them, and they've decided to go running every day when previously they haven't. So running's not bad for you. Running's good for you. But if you haven't run much before and you try doing it every day, then we know that that's probably is the change in load through your body that starts to cause those problems.
Sure. Okay. Look, I mean, that's been really helpful, and it's a really good introduction for our followers just to meet you, see you, hear a little bit about your speciality and the sort of things you see with all us midlifers. So if it's okay with you, I'm going to start with James, because we've got a few questions in that came in advance. So I'm just going to turn James's video on. There we go. Hi James.
Hi.
Hi. So the first question, they're all going to actually be anonymous. I think it's just easier to do that, but everybody's watching and they know the questions they ask. So our first question from one of our members, I've been suffering with lower back and hip pain, so it may be for a couple of you to answer, mainly when walking, but it's now starting to be present when standing and not mobile. I'm 49, just recently started on HRT. What can I do to ease the lower back pain and hip pain, or am I just going to have to live with it?
No, we're certainly not going to have to live with it. I think the first thing to establish is where the pain's coming from. A lot of times people describe hip pain, but it's not coming from the hip. I mean, classically, hip pain is perceived in the groin, and it can be felt all the way around the buttock and side of the hip and so on. But classically, hip pain from the hip joint itself is felt in the groin. And it may be that you've got two problems, if there is truly hip pain, or it may be that the pain you're describing relates to the pain in the lower back. If you've got pain due to wear and tear in the lower back, it may radiate down into the bottom, it may radiate down to the side of the hip, and it can radiate down a little bit further. And that can relate to a trapped nerve, but it can just radiate around in those areas just due to the wear and tear in the discs and the little joints at the back of the spine called the facet joints. So the first thing I think is to try and understand where that's coming from. And I think if you've not been to see your GP with that, or been to see a physiotherapist as a first step to assess exactly what the pain is, I think that would be the first step. But certainly, I think to sort of say at 49 you're all washed up and you're just going to have to put up with it was not very sensible. There's plenty to do, but I think the first thing is just establishing exactly what the cause is.
Yeah, I've realised a lot of people, they say they have a pain and you're never quite sure where it's coming from. So I guess this lady would start, as you said, go to GP and then decide whether they're going to see Jonathan or James or possibly both.
And it can be quite difficult. To work out where pains are coming from, particularly around the hip. I remember a few years ago having a pain around the hip and sort of front of the hip and back, and I thought I'd be a nightmare if I went to see someone because I couldn't really say where it was. It's very difficult to describe where the pain was.
Yeah.
But we're usually able to work it out.
Yeah.
Eventually.
Okay, I've got a couple more for you. I mean, they may all be a bit similar. So one of them gets migraines again due to back problems from hypermobility. She sees a physio who helps for a bit, and she's seen an osteo who's helped for a bit, but she's usually back to square one a couple of weeks later, and she wants her to basically see someone to sort out these back problems and migraines. I don't know if that's something you'd like to address.
Yes, well, that's a whole can of worms, and it's a particularly a whole can of worms when the word hypermobility comes into it, because if if you're truly hypermobile, and there are ways of defining that in terms of scores that you can do to look at various joints as to how mobile they are, the fingers, thumbs, elbows, knees, and the spine, and the score can be given to that. And you're getting symptoms that may be related to that. It's probably well worth arranging to see someone who has an interest in hypermobility, because there's a whole sort of science of looking at that, and a whole number of patterns of symptoms that go along with it. So it's probably worth looking at that. Migraine secondary to back problems is not a sort of typical thing. So if you're having neck pain and headaches simultaneously, then the two things can be related, and they're most commonly related just by the fact you've got wear and tear in your neck, you get tension in the muscles at the back of the neck, and that induces a tension type headache. True migraines, either classic migraines in which you've got an aura, visual disturbance, nausea, and have to go and lie down in the dark room, can be seen associated with neck pain as well. And there are a number of triggers for migraine, and just having some neck pain can be that. And if you're getting true migraine, then and you're getting it commonly, then it may be worth speaking to your GP about starting on one of the potential treatments to prevent you having migraines, and the number of tablets that can do that. There's a whole load in there that's difficult to sort of unravel, because there may be low back problems, there may be neck problems, there's the hypermobility to look at, and the migraines, and they may all be separate, they may all be tied together. There's a bit to work out there.
All right, well, no, I thank you. I mean, we obviously can't give, diagnoses over Zoom, but it was good to hear. I'm going to ask you one more, James, and then if you don't mind, I will move on to Jonathan. And this is, I said to you at the beginning, we've had loads in again about sciatica. So there's a couple which are pretty similar. They've had injections in the spine, they get a pain radiating down from her bottom down the hamstrings, and has tried things like epidural injections and steroid injections, and also the sciatica going down the leg. So you did cover that a little bit at the beginning, but what advice can you give on that?
So if you've got pain radiating down your leg from your back, then the first thing to decide is it sciatica? So is it a trapped nerve pain in the back, or is it something that looks like that? And several things can look like that. Problems with the hamstrings, problem in the hip, and so on. But if you've truly got sciatica due to a trapped nerve in your back, there are fundamentally three ways of managing that. One is you just put up with it until it goes away, and you can, during that putting up period, you take painkillers, you modify your behaviour so you're doing things that don't hurt. And if you need to lie in a funny position with your leg in the air to do that, you may have to do all of those things during the worst of it. Once it settles down, you then start getting back to normal life, and you have physiotherapy help with doing that. So one thing is to do nothing at all. 2/3 of people probably settle down over about 3 months with an acute attack of sciatica if you do nothing. If the sciatica doesn't settle down, then really doesn't settle down, then the solution to it is probably going to be a surgical one. The timing of intervening will depend on a whole load of things. It'll depend on the severity of the pain. I mean, if it's absolutely terribly severe, nothing else is working, then you might intervene surgically relatively early. If it's not too bad, you might leave it longer. If you've got weakness, numbness, or there are any of the other worrying features that we look at inside sciatica, again, surgical intervention might be a little earlier. If you're waiting for it to settle down and you haven't got quite to the point of having an operation for it, then injections into and around the nerve can be very helpful. But that's not typically something you'd pursue and pursue and pursue. It's a short-term solution to try and tide you over what you hope is going to be a good natural history.
Yeah.
But if you're getting persisting sciatica that keeps on and keeps on, then it's almost certainly solvable should you want it solved.
Okay, thank you. That's really helpful. So, Jonathan, I'm going to ask you, we had a message in this morning from a lady who said she has destructive, excuse me if I get this wrong, is it chondroplasty kneecap?
Chondroplasty, yes.
Okay, and lateral release surgery on her knee 6 years ago, which left her in more pain than before the op. Swollen knee and pain that shoots up into her thigh and hip. How will she know when to seek further help and what sort of help she should seek?
Yeah, good question. The problem with a lot of knee operations is they're not 100% successful. So knee replacements, for example, about 80–85% or so of people are happy. So what she's had a chondroplasty means we've tried to do something mechanical, keyhole inside the knee to try and get some of the cartilage to grow back. There's a few ways of trying to do it. We can drill some little holes through the cartilage into the bone underneath, and that releases a small number of stem cells, and they can make a sort of a scar type of cartilage, a fibrous cartilage. Or we can just take away some of the rough tissue on the outside of the cartilage. During the process of it wearing out, it can go through a phase where there's lots of sort of little fronds growing up from one side and down from the other side, and they just catch on each other. It sounds like she may have had that. A lateral release is an operation where the tissues are too tight on the outside of the knee, and they're released to try and centralize them across. Again, it's a little bit difficult because it's quite a tricky judgment to know how much to release. And if you release not enough, it doesn't quite work. And if you release too much, it can make the knee quite wobbly. So there's a few options. The first thing to say is that your kneecap, your patella, just lives in your muscles on the front, the big quadriceps muscles on the front. So if you took those muscles off, your kneecap would fall on the floor. So having strong quadriceps muscles is absolutely high priority if you have any problems with your kneecap. So virtually anybody who I see who has a problem with the kneecap, whether they have surgery or they don't have surgery, is going to go and see Eric and the like and have some treatment. So that's normally the first port of call. If the strength is very good, and even with that strength you're still getting a lot of pain, it can be worth getting a fresh MRI scan, and that can give us an idea of a few things. So in female patients in particular, it's quite common that the shape isn't right. You had your dysplastic hips. You can have dysplastic patellofemoral joints as well. But that about 35% of women have a mild dysplasia of their patella. So going and seeing somebody, whether that's Addy or me or Eric, having a good look, and if we're really confident that's a pain generator, getting an MRI scan and then looking at the shape can be helpful. Then there's a few options. Painkillers, we can do injections again. Sometimes that's necessary to get the pain and inflammation down enough that you can then go and work with Eric and get your strength back. And sometimes it's just too worn out, and we can replace the back of the patella and the front of the knee in something called a patellofemoral replacement. So there's lots of ways it can be treated, and if it's at the point that it's interfering with your life, come and see any of us.
Okay, thank you. Very helpful. I'm going to ask you a couple more and then we'll move on. So this lady has, well, she basically, the way she's written it is clicky hips, ? Okay. What can I do?
Okay, yeah. Clicky hips on their own don't necessarily need an awful lot done about it. It probably merits a trip to your GP to have a look and see whether it's some tendons that are snapping over the outside of it. If they're pain-free, then you really shouldn't be trying to have anything done surgically, and we wouldn't be trying to get injections done. And it's likely that it's going to be something along the lines of an underpowered gluteal muscle that's just letting everything just get a little bit out of balance in there. If they're clicky and they're causing pain, and particularly if they're causing pain when you bend up and rotate inwards, you may need to have some further investigations. If the ball and socket hasn't got a hard edge on the socket, there's a soft fibrous lip on the socket, which basically stops the two bones banging together. You can tear that lip. It's quite common in sports people, quite common in runners, and sometimes that does need treatment.
Yeah, because she said at the moment climbing up the stairs is like the highest mountain, and she's got pain in the hips and they're clicking all the time. So it sounds like she probably needs to get that looked at.
Yeah, and certainly if you've got groin pain, that's worth having a look at, and that should be imaged, starting with plain X-rays, but often an MRI is really helpful.
Yeah. Now, a lot of these questions are asking about, are there any supplements women can take? Yes, they're talking about calcium, vitamin D, iron, all sorts of multivitamins, complex B. Is there anything women should be taking to protect joints and hips? Or
I think in terms of protecting your bones, we're getting more and more evidence that essentially we don't quite have enough sunshine in this country, and that the majority of people are vitamin D depleted. There was a lot of work looking at black skin, Asian skin, and the factors they have in terms of vitamin D absorption. But I think it's now becoming quite clear that actually a lot of people are vitamin D depleted. Vitamin D testing is becoming very commonplace, and in terms of strengthening bone, vitamin D and calcium supplements together do seem to be quite useful. HRT is useful in terms of maintaining bone strength. Unfortunately, when it comes to cartilage, it's a little bit more complicated. The most famous options have been something called glucosamine, which is a key constituent of cartilage. We've had lots of studies looking at up to hundreds of thousands of people trying to work out if glucosamine works. The problem is we're trying to measure whether you're going to be less worse off in 10 years' time if you take some glucosamine, and it's a very subtle sort of thing. So we're not seeing, well, we know it's not growing cartilage back. And the evidence to suggest it's slowing down cartilage loss is quite weak, but it's relatively harmless, and it's reasonable to take. The next is chondroitin, similar, probably even, if anything, slightly less evidence for its use. But I think glucosamine and chondroitin supplements may provide some help. Obviously, some of the more interesting things in terms of turmeric and the anti-inflammatories, we don't as yet have any clear medical evidence that that's doing anything, I'm afraid to say. And I would say that you need to have a little bit of a note of caution. Some of the herbal remedies can interfere with other medications, particularly medications for blood clotting. So you do need to be careful if you are taking any supplements, particularly any that aren't the regular vitamins and minerals. You should probably check with your GP first. They're not going to interact with anything else you're on.
Sure. Okay, that's very helpful, because a lot of people talk about turmeric, and I always wonder if there's any evidence behind it or not. All right, we're going to move on to feet. So Andy, this next question: I have joint pain in both my big toes. I'm 44 and I've had this since I was 40. I love walking, but I'm concerned it's going to get worse as I age. What can I do or take to help it?
Okay, so well, I suppose the first thing to say is the big toe's very complicated joint. We've just heard about the knee. If you think of the knee, which has a kneecap in the front of your knee, imagine having two kneecaps and putting all your weight on it and walking on your kneecaps. That's what the big toe is. It's effectively a hinge joint with two bones underneath it. They're P-shaped bones called the sesamoids, and they sit under your big toe and they glide. And the force going through your big toe is huge. It's a bit like a car jack. So you're lifting up a huge weight every time you walk on it. So it's no wonder that the big toe can get pain and get wear and tear. There are other things and diseases that can affect the big toe, like gout or inflammatory joint problems. And so it's really important to get a diagnosis as to why this person's got pain. But the commonest cause really is wear and tear as you get older, and for the reasons that I said, and we call it stiff big toe, or hallux rigidus is the Latin term. The things that you can do to avoid it really is to stop overusing that joint. Okay, so you should avoid squats, avoid things. I know a lot of people take up things like clams and they think that's a good exercise, but in clams you put your entire weight flexing your big toe. You don't realize the huge force you're putting on it. So you just avoid that. You change it. You can do a plank, for example, by wearing trainers and not flexing your big toe. You can do squats without flexing your big toe. You can avoid wearing high heels or things that make motion on the big toe. Sometimes just lowering the heel by 1 inch can do things. And then, you know, if a diagnosis has been made and it is wear and tear, there are loads of things that we can do now. We can do injections, changes in shoe wear, and obviously there's lots of surgical treatments that are available should that come to it.
Okay, thank you. Very interesting. One more. Would love to know what to do about sore Achilles tendon, I think at back of ankles. It seems to be a very common problem with some of my friends. We're all in our 50s, but it's very sore to touch, feels bruised, particularly when I get up in the morning or if I'm sitting for a long time. Also, I can't walk for more than about half an hour with discomfort. It's stopping me from exercising. Do I need to weight train and get the muscles stronger around the knee? I do yoga, lots of walking. I wish I knew what it was. I am on HRT, which has helped a little, but would like advice, please, on how I can improve further.
Okay, so the Achilles is a big problem. Okay, so the Achilles is one of the biggest tendons in the body. It connects your calf muscles and it goes across two joints. It goes across the ankle joint. It goes across the joint below the ankle called the subtalar joint. And the muscles and the tendons that connect it also go across the knee. Okay, so absolutely right that think problems around, we said before, core stability, problems around your knee can lead to problems around your Achilles. And one of the commonest problems is that the hamstrings and your calf muscles are tight, too tight, and that you stretch and you actually overstretch the tendon. So one of the biggest problems is overstretching. Now, a tendon is like 1,000,000 elastic bands. Okay, and you know that with any elastic band, you stretch it, and as you let go, it goes back to its normal shape. But if you stretch it beyond its elastic limit, then it behaves like a slinky without its slink, or an elastic band that's lost its stretch. And that's sadly what happens in tendons. As you stretch them, sometimes accidentally while you're running, or sometimes falling off a step, and you stretch them beyond their elastic limit, and a few of the fibers tear. And that's causes pain, it causes inflammation, and it causes swelling, and eventually you're left with parts of the tendon that become degenerate. They're no longer healthy, and that's what a tendinopathy, as we tend to call it, is. And it affects it affects your shoulders, it affects your Achilles, lots of other joints as well. And so the key bit is to avoid overstretching and to strengthen all the muscles that we talked about. And the real key to treatment is what we call neuromuscular retraining. So if you imagine a football team, if someone supports Arsenal or Tottenham or Man City and they get a player sent off, then what you have to do is you can't bring on a new player because you've lost one. And so what you do is you improve the way the other players play. And the same thing applies when you've got a tendon problem, a tendinopathy, is you have to train the muscle to behave better with the limited tendon that's connecting it to the bone. And neuromuscular retraining involves balance work, it involves strengthening work, but usually not necessarily stretching work. And I'll later reserve, Eric, I'm sure will have a lot to say on this, because it's really important to look at the body as a whole, not just at the Achilles. And you know, if someone is suffering, there are loads of treatments available. Physiotherapy is one of the mainstay of treatments, but there's loads of other treatments. For some reason, they seem to begin with an S: shockwave, stem cells, surgery, and all the other things that are available. But you shouldn't be left with pain, and certainly not when you're young in your 50s.
Yeah, all right, thank you. I'm going to hopefully come back to you for one more at the end, but I just want to make sure we've got time to fit in a couple of questions for Adi and Eric. So Adi, this lady has a historic back spinal injury that's causing pain and numbness, and she wanted to know, and it may be again for James or for yourself, whether she should see a sports exercise specialist or a personal trainer, or go straight to see a spinal surgeon. Should welcome any ideas you have. She'd rather start by trying to treat it through exercise, she says.
Well, first of all, commiserations for having pain in your back. And I think the first thing to say is, if you have a historic back pain, what is that history? But then the second thing from what she's mentioned is the fact that she has numbness with that. Now, as Jim has mentioned earlier on, back pain tends to be canvassed, and everyone treats it the same. But if you're having pain that is associated with nerve symptoms, so we're talking pain radiating down your legs, pins and needles, numbness, which is altered sensation, then really that should be looked at. And if you also then have a history of back pain or a history of back problems in the past, whether that's known history of wear and tear or previous surgery, then it may be worth seeing someone to try and get an at least up-to-date diagnosis to find out why you're having numbness. Now, that person could easily be a spinal surgeon or a sports and exercise medicine physician or a musculoskeletal physician in that sense. The point is, it's best to see someone for, you could start with your GP at least to at least make sure you don't have anything that needs an urgent attention right then and right then. But she doesn't have to be concerned about going to see a spinal surgeon, because not all surgeons like to operate, and in fact the good surgeons are the ones who know when not to operate. And like Jim has already mentioned in his previous talk, if it is a disc that's bulging and irritating a nerve, and it is fundamentally because she is a bit weaker core strength, it may be that a bit of rehabilitation with Eric. It may be the medication to counter that pain. It may be an injection to tide her over so that she can get strong, and that in itself may then take away the pain in itself. But if those symptoms persist, and most importantly, they are intrusive. So that's a classic question: when should I go and see someone for my pain, irrespective of whether it's a back pain, shoulder pain? If it's intrusive, stopping you from doing what you want to do. If it's stopping you from sleeping, stopping you from having a quality of life, then really you should be seeing somebody.
Yeah. Okay. The next question: during lockdown, I've been quite active. This isn't me, by the way. This is the next lady, although I have been quite active. She's been playing tennis, golf, cycling, swimming, training, and now she's developed tennis golf elbow, which she's never had problems before, and sore achy knees. Mostly the knees started, she said, when she was emptying the washing machine. So my advice: don't do the washing. Simple solution. So yeah.
So the question is.
Oh, sorry. Tennis, golf elbow, and sore and achy knees.
Okay. So first of all, tennis elbow describes tendinitis, as Andy has mentioned earlier on, which is a bit of overuse, wear and tear of the tendon of the forearm. So your forearm muscles, you can divide them into the extensor compartments, the ones that are responsible for taking your wrist back, and the flexor compartments, the ones that brings your wrist forward. So all the muscles responsible for taking your wrist back, they all come together at one point on the side there, and that's your common extensor tendon, and they attach to your lateral epicondyle, the lower end of your elbow. So responsible for partly to help extend the arm a little bit, but really for your to extend your wrist. On the other side, all the muscles responsible for flexing, they attach the inside of your elbow there. And so that is where we would describe as a golfer's elbow, and that is why we would describe as a tennis elbow. The matter of fact is most of them have nothing to do with tennis or golf. Most people who present, it's simply because of the position the position you hold your arm like such. So if you are somebody who is holding a object for a very long period of time, you're even working at your desk for long periods of time. I've seen it in runners, because they hold their arms in flex position while they're running all the time, and then they go off and then start extending it. Or you suddenly lift something heavy for a start. You're used to lifting a regular weight, and then you suddenly build up your weight very quickly. Or like many people in their 40s or 50s who decide to get into HIIT type classes, and they start trying to do chin-ups and pull-ups and lifting big heavy bars. That big arm grip that you're doing can cause you to have a tennis elbow or a golfer's elbow. Now, these things are overuse, and as Andy mentioned earlier on, there is no one solution that will fix all of them. If you see somebody who says this will cure you, they are lying. The reason why there are so many modalities, your shock waves, your injections, is because there isn't one, and it may be accumulation of all of the above that helps sort it out. But fundamentally, the management is one, activity modification, looking at what you're doing that may be provoking it. Number two, working with a good physical therapist, someone like Eric or as a team, and the aim would be one, to try and stretch those muscles, and two, to strengthen them. And there is a way by which they are strengthened. We start with isometrics, which basically means you hold the weight and then you gradually increase, because you're trying to ask these tendons to adapt to load, basically. Mm-hmm. So that's how you, and that's the same for both sides.
Okay, thank you. I'm going to ask you one more, and then I want to go on to Eric, and it's only because we get asked this all the time. Loads of women have started this Couch to 5K, loads and loads of them, and we must have had about 6 people complaining of suddenly getting lower back pain that sort of come from doing that, and some of them are running on the street and on the treadmill, but it seems to be just a common thing. And even if they're sort of walking for 5 minutes, running for 20, you know, that kind of approach. And it may be something that Eric might want to help answer as well, but is there a right or wrong way to approach this Couch to 5K?
Well, first things first, congratulations to everyone who's tried it. I've done the Couch to 5K as well, and I did it just before the knee and the turn of the year, because I was seeing patients who are presenting with various ailments. And I wanted to see what they were going through and wanted to experience it myself. Is there a right way or a wrong way? There is no one way that fits all. Fundamentally, the Couch to 5K is a graduated method by which you increase your running distance. You start from very, very low levels of walking, running, to reducing your walking intervals and increasing your running intervals, till eventually you can do a sustained run for a full 5K or roughly 30 minutes. The thing that the Couch to 5K it does mention occasionally, at least on the NHS BBC one, but it doesn't emphasize so much. The 2 main things I experience is, number 1, is the strengthening element of it. The Couch to 5K at the end of each one talks to you about stretching, etc. But actually, as your load increases, as you start to move your body through space, pounding whether it's the pavement or the treadmill, you need to be strong, and your core needs to be strong. And if all of that is weak and you start to move around a little bit more, guess what? Your back is going to be taking the pounding, your knees, your hips, your joints. So it's important that you incorporate a strengthening program into that. And that could just be some body weight exercises. But if you're running 3 times a week, you need to be including strength work twice a week with that as well. The other thing that the Couch to 5K doesn't emphasize is, if you're thinking in my head, right, my schedule is I'm going to be running 3 times a week. As your running distance increases, the time you're actually running, your recovery days may also need to increase. So instead of doing Monday, Wednesday, Friday, and then having the weekend with the family, you may need to be doing Monday, Thursday, Sunday. As the distance increases, the gap between those runs needs to increase so your body can adapt. And if you find that you're beginning to pick up niggles, say on week 8, instead of just quitting, step back down to week 7, or even step back down to week 6. All of this is not wasted. It is all exercise in the bank, so to speak. And then you build back up. You don't have to complete it in whatever 12 weeks prescribed period. You can take as long as it matters. But if you do then have persistent symptoms that are not going away, that's when you should go and see somebody about that.
Okay. And Eric, thank you. Eric, do you see a lot of people come to you after this Couch to 5K?
We do. I probably don't see as many after the Couch to 5K, because I think it's a really good program, because it's that progressive loading over time. We tend to see more people coming in who've rushed it, who've tried to do the London. Well, exactly. The marathon time. There's a reason we see so many runners, is because people find out they've got the place in the marathon in normal times. They find out in October, and then Christmas gets in the way, or the festivities and holidays get in the way, and they decide in January they're going to start the marathon training, because they've just forgotten to do it for the last 2 or 3 months in the cold winter weather. And we see them in February, when it's 4 or 5 or 6 weeks after they've decided to make up for lost time, and they've just done it too quickly. And so that's much more common, what we're going to see in terms of when running injuries come in. So it is just about trying to adapt and adapt at a rate that your body can handle.
Sure.
And we're all a bit different in that.
Absolutely. So look, I've got a question that's just come in for you. I've dislocated my elbow 9 days ago, and the orthopaedic doctors told me it requires physio and rehab for the best chance of recovery. It's been in a sling resting, and now it's time to mobilize it. I'm unable to fully straighten it, but hoping with the right care I can get there in the end. What would a physio do and to help me, and how long would I need to see them for?
Yeah, a dislocated elbow is a pretty big injury. It takes a lot of force to do that. If you've got to fall over pretty hard or pretty awkwardly to do that for most people. it's a really strong joint. So usually the good thing is elbows heal really nicely. The bones in the elbow, they're solid joints and they heal really well. There's not necessarily going to be more dislocations down the line, but yeah, it's a very stiff joint. And so what we typically do in that situation is we get in there and we put a bit of welly into it, and we have to move it and bend it and straighten it and help people really. It's not just to get it straight, it's also being able to bend it up to reach up and do your hair or reach behind your back and those sorts of things. But it is quite often just really encouraging people to move and using manipulation and manual sort of pushing and pulling and massage and things to loosen that joint up, and showing them how they can do it at home as well.
Yeah, I was actually going to ask.
To help them.
I was going to ask you whether so. I mean, that's quite interesting. And from a personal point of view, I might as well, I've got you here. My son has had a pin put in his sort of thumb, so that kind of joint, and has been in a sling for 4 weeks. So in 2 weeks, that's coming off. He'll need physio. And I'm asking a lot of people have broken arms. It's not obviously just for me. But in terms of coming in for physio for that kind of thing, is it something that they can only see you for, or is there stuff they can do at home to
Definitely. It's really important that most of the improvement they're going to see is from what they do at home. So we'll typically assess somebody based on the information we get coming from the surgeon as to what the particular injury is and how far down the healing stage they are, as to how the bones are and has it healed really well. And when it's time to start people moving, then that's the biggest number one thing we want to do, is show people how they can do it themselves at home. And most of the improvement will come from that side of it.
Sure. All right, I'm going to ask you one more and then we must wrap up. I've kept you all here long enough. This lady, tendinitis. I've been to see my physio for the last couple of weeks. Any tips apart from ibuprofen and paracetamol? It's on the inside of my elbow joint, so bicep and tricep tendons are impossible to rest it. I've been in agony for 6 days now. Should I go back to my physio or just try some over-the-counter medications? Apparently she did it with an outstretched arm to prevent a fall.
Okay. So as per Addie's comments there before, the inside of the elbow is the golfer's elbow, part of the tennis elbow and golfer's elbow. I think one of the important things, unfortunately, tendons are rubbish at healing. They're really slow to change. The adaptations they take quite some time. So in that first phase, we definitely want to get on top of the pain, and your ibuprofen gels, sometimes acupuncture and things like that can help to settle the pain. But yes, it does take a little bit of time for that acute reactive phase to settle down before we then start to see the improvement. So I think I'd try and reassure somebody, if they're only 6 days since it happened, first of all, we want to make sure it's tendon, but if it is a tendon issue, then it can take several months really to settle down and be comfortable.
Sure.
They're just slow to adapt.
Sure. All right. Well, look, there was a lot we didn't get through. So there's a lot of questions on things like rotator cuff injuries, that came in for Addy, and there was a lot about plantar fasciitis and more about flat feet and bunions that were coming in for you, Andy, and a lot on arthritis of the knees and hips, and lots more spine questions as well. So we've run out of time. So what I'm going to do, thank you all of you for giving up your evening. I really, really appreciate it. It's been so helpful. Anyone who's watching who didn't get their questions answered, what I'm going to do is I will email them to our doctors, and we can give generic replies, but please, if you'd like to see anyone at the Wellington Elstree Hospital, and for those of you who are not necessarily living in London, UK, that's North London, you can contact me on katie@lattelounge.co.uk, and we will put you in touch with our doctors at the Wellington in Elstree. And please don't forget to follow us on all our social channels, and most of our doctors, I think, are also on social media. And we will embed this in a blog, and we will share it to all our social channels, and we have our directory, all of our doctors are in our directory on our website, so you can find all their contact details there. So thanks everyone for watching, and thanks again, guys. It's been really great having you here, and have a good evening.
Thank you.
Take care. Thanks.